Okay, well, welcome. Thank you so much to everyone for attending and for inviting us to give this presentation. We're really excited to share our work with you today. These are our disclosures. Our learning objectives today will be to discuss treatment guidelines for infantile hemangioma with oral propranolol, to gain knowledge about when to do imaging for infantile hemangiomas, and to describe which patients are at highest risk for airway hemangiomas, neurovascular complications, and cardiac anomalies, and then determine when to refer. So this will be a four-part series, four-part lecture, as you just heard. And so the first part will be my part from a dermatologist perspective on treatment and diagnosis of infantile hemangiomas. So infantile hemangiomas can have a variety of different presentations. The top left corner shows a superficial hemangioma. These are very thin, bright red vascular birthmarks, but they can also be quite large and deep, as shown in the top right. And we're going to get a little bit into PHACE syndrome in a minute, and PHACE is an acronym for segmental hemangiomas that are associated with multiple congenital anomalies, and we'll tell you more about that acronym as we go on here. But I wanted to draw your attention to the distinction between focal, which is sort of a small, round infantile hemangioma, and a segmental hemangioma, which can be spanning a region over the face, usually on the forehead, the beard distribution, or down the central face. And these segmental hemangiomas are the ones that have the highest risk for PHACE syndrome. For pediatricians here in our audience, it's really important to understand the growth characteristics of infantile hemangiomas. They are present at birth or become visible early in infancy. At birth, they're often confused with a port wine birthmark because they could look just like a flat pink patch. Or they're also often confused for birth trauma or a bruise. Or they may just appear as a blanched area of skin with very faint telangiectasias. But it's really important to recognize these because the most rapid growth phase is between 1 and 3 months of age. And although infantile hemangiomas go through this growth phase for several months, then plateau, and then actually spontaneously involute or regress, they can leave permanent skin changes that can be life-altering for the individuals that experience this. And the thick superficial hemangiomas probably have the highest risk of scarring. So these are the hemangiomas with a really sharp border, and they stretch the skin and can leave behind scarring or fibrofatty tissue. But it's important, this is very important to recognize because there's a window of opportunity to problematic infantile hemangiomas. So consult early by 1 month of age for lesions that are potentially high risk. And the American Academy of Pediatrics published a clinical practice guideline in 2019 about the risk of about which infantile hemangiomas are highest risk. So some hemangiomas can be potentially life-threatening, and one of the most dangerous types of hemangioma are the airway hemangiomas, which we'll hear more about in the next section of our talk. In addition, another feature which is not related to PHACE, but that I just want to highlight here is that infants with 5 or more infantile hemangioma can have a risk of liver hemangioma. And diffuse liver hemangiomas could be also potentially life-threatening. So it's important to get a liver ultrasound in infants with with 5 or more infantile hemangiomas. Other reasons to refer early are hemangiomas that are high risk of scarring, that can cause functional impairment, or have a high risk of ulceration. And hemangiomas on the eyelid can grow rapidly during infancy and obstruct the visual axis and lead to blindness. So that is also a very high risk area. And then we're going to get more into the associated structural anomalies in the next few slides. So what are the medical therapies for infantile hemangioma? So there was a serendipitous discovery that beta blockers can be very effective in the treatment of infantile hemangiomas. This was first discovered because we used to use prednisone to treat infantile hemangioma, and the side effect of prednisone is high blood pressure. And the prednisone was not very effective, only works in about 40% of patients. But when they gave oral propranolol to treat the high blood pressure, they noticed that suddenly the hemangioma shrunk. And that was how propranolol became our treatment of choice for infantile hemangiomas. And this was FDA approved in 2014. And propranolol is a non-selective antagonist of beta-1 and beta-2 adrenergic receptors. For initiation of propranolol, we recommend, or the guidelines are to start treatment in the inpatient setting for premature infants or infants less than 5 weeks corrected age. And propranolol can be initiated in the outpatient setting for infants greater than 5 weeks corrected age. The general dosing is 1 to 3 milligrams per kilogram per day, divided twice daily or 3 times daily. And we've discovered that rebound, if we continue treatment for 12 to 15 months of age, then there's a much lower risk of rebound or regrowth of the hemangioma after stopping propranolol. Although bradycardia and hypotension are theoretic risks with the beta blocker, the most severe the most concerning risk factor with oral propranolol is hypoglycemia. And so we extensively counsel caregivers on administering the propranolol with feeds and holding the medication if the infants are ill, have a high fever, vomiting, or poor feeding. We also recommend that for younger infants less than 6 months of age, that they do one nighttime feeding at the 6-month mark to avoid a prolonged fast that might lead to hypoglycemia. And signs of hypoglycemia could include sweating, anxious appearance, tachycardia, seizures, or lethargy. And with the hemangioma investigator group, we have developed these hemangioma care guidelines, our caregiver instructions. It's at hemangiomaeducation.org, and the video is in English, Spanish, and French. So in addition to the oral propranolol, there's also topical timolol. However, this is not FDA approved. It's an FDA approved. The FDA approved indication is for glaucoma, and it's off-label use for hemangiomas. Timolol is most effective for superficial hemangiomas that are less than 1 millimeter thick, and the dosing guidelines are 1 drop twice daily applied directly to the hemangioma. So the segmental facial hemangiomas can be associated with congenital anomalies in 30% of cases. So it's really important to screen. And we'll get into that in the next slide. But Ilona Frieden was the first one to describe the acronym PHACE, or describe the association of infantile hemangiomas with structural anomalies in 1996. And she coined the term PHACE for posterior fossa malformation, hemangioma, arterial anomalies, cardiac defects, eye anomalies, and sternal defects or supraumbilical raphe. With Ilona in 2006, we started the PHACE registry. And since that time, over 300 families have participated in the clinical characterization, genomic, and natural history studies. A collaborative study was led by Colleen Cotton and the Pediatric Dermatology Research Alliance, or PEDRA, to answer the questions of which patients with segmental facial hemangiomas are at highest risk for PHACE. In this multidisciplinary study, 242 patients with segmental facial hemangiomas were evaluated. The figure on the right shows the segments, in case you're not familiar with them, but S1 is on the forehead, S2 is the medial cheek, and then S3 is the beard distribution, and S4 is down the central face. And the highest risk regions are S1, S3, and S4. And larger hemangiomas greater than 25 centimeters squared is also a risk factor for PHACE. Lower risk lesions are the isolated parotid hemangiomas and S2 segment, although the risk was not 0 in these patients. Finally, there is a low risk of PHACE without a facial segmental hemangioma. One example is large segmental hemangiomas on the chest and upper arm. These have been associated with cardiac and arterial anomalies, as well as sternal scarring. And then a segmental hemangioma on the lower body can be associated with congenital anomalies as well. And this is known by the acronym LUMBAR for lower body hemangiomas, urogenital anomalies, myelopathy, bony deformities, anorectal malformations, arterial anomalies, and renal anomalies. In 2016, we published consensus-derived diagnosis and care guidelines. And this is a free article. So you can take a picture of this and if you want to refer back to it. But basically, in addition to the specialists who you'll hear from today, endocrinology, hearing, dental, and mental health issues are also can also occur in PHACE syndrome. So what screening recommendations are needed in PHACE? A careful physical exam should be done to assess for sternal defects and supraumbilical raphe. And for those of you who haven't seen a supraumbilical raphe, this is a picture showing it here. It's sort of a fold of skin above the umbilicus. A referral to cardiology should be done for an echocardiogram to determine if arch anomalies are identified, and that will be discussed more later. And then an MRI and MRA of the head, neck, and if possible, aortic arch to assess for risk of, or to assess for high risk arterial anomalies. And we'll also hear more about this. And then an ophthalmology exam should be done. As I mentioned before, the hemangiomas on the upper eyelid can be associated with functional impairment, but you can also have developmental anomalies in PHACE syndrome, such as optic nerve hypoplasia and persistent fetal vessels of the retina. So there was some concern about whether oral propranolol is safe to use for the treatment of hemangiomas in patients with PHACE. In a multi-center retrospective cohort study with 11 tertiary care centers between 2010 and 2017, we investigated 76 patients with PHACE syndrome receiving oral propranolol. And luckily, there were no reports of serious adverse events such as stroke, transient ischemic attack, or cardiovascular events. There were the common propranolol side effects like sleep disturbances, minor GI upset, and minor respiratory tract symptoms. So our recommendation is that the lowest possible dose of propranolol should be used in patients with PHACE, and that it should be divided with 3 times daily dosing to prevent large fluctuations in blood pressure. And the one relative contraindication is uncorrected severe aortic arch obstruction, and we recommend managing with cardiology in this situation. So what is the cause of PHACE? This is what my main research focuses on. And so we have ongoing registry studies to identify this, looking at genomics, using induced pluripotent stem cell studies, and also looking at radiology and immune biomarkers to predict which patients are at greatest risk of neurovascular complications. If you have any patients with PHACE syndrome and you'd like to refer them to the registry, please scan the QR code here for more information. I'd like to, my contact information is here if you have any questions, and I'd like to thank the PHACE syndrome community for all of their support, as well as our PHACE registry funding sources. So with that, we'll hand it off to the next section.
All right, good morning, everybody. So I'm Karthik Balakrishnan. I'm one of the ENT airway surgeons here, and also have the pleasure of working with Dr. Leonard in the hospital leadership side. Thank you for the chance to join you. So today I'll talk with you very briefly about some airway considerations. As Dr. Siegel said, Airway hemangioma or airway involvement with hemangioma is one of the more feared manifestations of infantile hemangiomas in general, and PHACE syndrome more specifically. And so we'll talk a little bit about some of the symptoms that can manifest as well as when to refer. The short story, just to keep it brief, is if you're worried, refer the kid, right? But what are the key functions of the larynx and the airway, right? When we think about airway, most of us think about breathing. But really, the larynx has three critical functions, not just breathing, but also swallowing and voice. Certainly in infants and young children, breathing is the primary consideration. Swallowing is almost as high of a consideration, and voice is the lowest worry. But that said, if you see problems with swallowing and voice, those can be subtle or not so subtle red flags that something is going on with the larynx as a whole. So it's important to be attentive to them. So, one easy way to remember it, I guess, is that red lesions on the skin may be red flags. So when we think about children who have cutaneous infantile hemangiomas in general, all comers, only about 2% will have airway involvement. So it's not a great number. But that said, infantile hemangiomas are very, very common. And so 2% of a big denominator is still a fair number of kids. So it's important to have some index of suspicion. When you have an infantile hemangioma in the beard distribution, then that number goes up dramatically. So up to 2/3 of children, depending on the series, may have airway involvement. But when we say airway, we mean not only the subglottis, which is the sort of classic textbook location, but also the pharynx. And you can imagine if you had a large pharyngeal hemangioma, it could affect both breathing and swallowing. When you have children with PHACE syndrome, that number is also very high. It hovers between 40 and 60%. So let's just say half, roughly, will have airway involvement. And that's whether or not you have a beard distribution infantile hemangioma. So when we look at the guidelines that Dr. Siegel referenced that were published in JPEDS, it doesn't explicitly mention uniform referral to otolaryngology, but really I think that if you have a kid with PHACE, you probably should just send them over, because if 1 out of 2 kids has airway involvement, they probably all need to get checked. Now, the converse, what if you have a subglottic hemangioma? How many kids have infantile hemangioma? How does that Venn diagram work? It's about 50%. But that's that's sort of a weird way to think about it anyway, right? So I don't think that's as useful of a statistic. So when we think about breathing symptoms, 70% of children who have airway involvement will have stridor. So stridor is certainly probably the most obvious or most, the first thing that may come to mind. However, as many of you as pediatricians know, the absence of noisy breathing is not always a good sign, right? If you have your asthmatic child who's in status, they may not have wheezing. That's not a good thing, right? And stridor works the same way, especially in young infants. They may not move enough air to generate sound or stridor. And so if you're worried, just get the kid checked. And I'll give you an example. On the left side here, you see an endoscopic view of a child's vocal folds and subglottis. And there's no opening in the subglottis for airflow. Actually, well, it's right there. That's their airway. So this is a child with subglottic hemangiomas who presented to clinic with minimal stridor and minimal distress and was hanging out with this airway. So children can hide airway problems very effectively. So again, I encourage you to have a low threshold for referral. On the other picture, you see an MR image. And again, you can see this enhancing lesion that occupies the vast majority of the airway lumen. How about swallowing symptoms? Up to 80% of children with PHACE may have swallowing problems. Sometimes these are subtle. And it's not always directly due to the hemangioma. So they may have hemangiomas not just in the airway, but in other sites like the pharynx or the lip that affects their ability to latch and feed. You may have posterior fossa anomalies, which of course may affect some of the cranial nerve nuclei that can control swallow function. And then if these kids have cardiovascular defects and have cardiac surgery, that of course can lead to vocal fold weakness, swallowing dysfunction, and so on as a secondary effect. And then in terms of voice, some of these kids can present with hoarseness. However, there are not great series telling us how often this happens. But to give you an example here in this image, this is a bit of a weird image, but we're looking along the length of the vocal folds here. So here's the left vocal fold here, the right, they meet in the front. And here's a hemangioma sitting here inside the left vocal fold. And that affects the vibratory function of the vocal folds and may cause hoarseness or breathiness of the voice. Some other red flags to look out for, of course, we talked about stridor. Retractions, as many of you know, are an even more worrisome sign of breathing difficulty than stridor. Swallowing problems, as we said, voice problems. I think if you have a child with infantile hemangioma or PHACE who's got any sort of dysphonia or voice concern, they should get checked, whether or not they've had cardiovascular surgery. If they have any failure to thrive that you may attribute to breathing, swallowing type problems, they should get checked. And then I think sleep apnea without another obvious cause, especially in an infant where sleep apnea should be fairly uncommon, warrants an evaluation with an airway specialist. So just really quickly, how do we assess the airway? There's two different ways, really. There's awake laryngoscopy in the clinic, and then there's operative laryngoscopy under general anesthesia in the operating room. Each has pros and cons. The main one that parents worry about is number 2 here. So in clinic, if you do an awake laryngoscopy, it's very safe, it's quick, there's no general anesthesia, the child's protecting their airway, but you have a very pissed off baby because you just put a camera in their nose. And especially, you can always tell the first time parents because they start apologizing to the baby. Baby doesn't care. It's not gonna remember it. But this is a really useful way to evaluate the airway in a very safe way. Looking in the operating room gives you a more thorough assessment of the airway and a more detailed assessment. And you can find lesions you can't see in awake laryngoscopy, but you've got general anesthesia. And that, of course, freaks parents out as well. But also, if a child has airway obstruction, then inducing anesthesia may lead to acute airway decompensation. So we have to think about that carefully. The reality is, any kid you send to me for assessment is going to get a clinic scope. So this discussion is sort of moot. But that said, it's a discussion we have with every parent every time. 40% of the kids who end up going to the OR for assessment need operative intervention. But you can imagine that's sort of a pre-selected group, right? If you're going to put them under anesthesia, you're probably more worried about them anyway. And here's an example of what it looks like in clinic. So this is one of our patients from Packard from about a year ago. Vocal cords, hemangioma in the subglottis. This is a left posterior subglottic hemangioma. If you look at some textbooks, they'll report that that's the location they always occur. Not true, but somehow they do seem to happen more often there, and I don't think anyone really knows why. But that's what it looks like in clinic. How about surveillance? If a child is on treatment, let's say with propranolol, how do we surveil them? Generally, this is done in clinic with awake laryngoscopy as well as assessment of symptoms. But I would think about going to the operating room if it's a hard to see location or if they've had prior airway interventions for the hemangioma, again, weighing the risks of anesthesia. But the reality is propranolol has rendered much of the operative management of hemangiomas unnecessary in the airway. This is a really fun operation. We all love doing it as airway surgeons. It's pretty much gone. We don't do it anymore because propranolol is so effective. But endoscopy is really essential in diagnosis and management. And sometimes if it's a dangerous airway, it's necessary to stabilize the airway. Now, for all of you, if you're working in the emergency department or the ICU or some other setting where you need to manage this airway acutely, positive pressure certainly can be helpful. If you have to intubate, these are compressible masses. You can weasel a tube through, but once that tube's in, it may be hard to get it out again. So at that point, it's worth calling for help once the tube's in. And I think really a low threshold for specialty referral to otolaryngology or an airway specialist is really important because, as I said, these kids can have problems with breathing, voice, and swallow, and they can be subtle or severe. So if you have any index of suspicion, just send them. We're happy to see them. All right. And with that, I'll hand it over to my next colleague.
Great. Good morning, everyone. I'm Sarah Lee. I'm one of the stroke doctors here at Stanford. I see both children and adults, so any age. And I'm here to talk to you about the neurovascular complications of PHACE. Really, neurovascular abnormalities are the most common extracutaneous feature of this syndrome. Up to 84% in one series had some type of neurovascular anomaly. So really high percentage. And I'll go through some of the major and minor criteria in subsequent slides, but most of the anomalies involve the medium to large vessels of the neck. So those are the carotid artery in the neck or the vertebral arteries, basilar artery, middle cerebral artery. So really the main conduits for blood to the brain. Most often, these anomalies occur ipsilateral, so on the same side as the facial hemangioma, but not always. We can certainly see quite diffuse arterial anomalies in these patients. And I just want to highlight too that structural brain anomalies, the posterior fossa anomalies, the P of PHACE, is also a prominent aspect of this condition, and can have some implications, as Dr. Balakrishnan was referring to, with cranial neuropathies and sometimes issues with balance and coordination. So what's happening on an ultrastructural level to these blood vessels? So here's just a H&E slide that's kind of showing us that there's really dramatic fibrointimal thickening of the blood vessel and the blood vessel wall, and you're getting loss of the smooth muscle and elastin in that vessel wall. So that renders that vessel prone to forming aneurysms, to taking a very tortuous course, to being very fragile in many cases. And I think what this also shows us is that sometimes the caliber of the artery may look normal on an MRA, for example, or a CTA, but on an ultrastructural level, we think those changes are probably much more widespread. So arterial ischemic stroke is probably one of the more feared complications of PHACE syndrome. So what are the mechanisms by which children have stroke in these situations? So there's a couple different ways. So the first is artery to artery embolism. So you can have complications of the cardiac system that can lead to cardioembolism, but you can also have pouches or strange anomalies or kinks in the blood vessel that can be prone to forming clots because of turbulent flow, and then those clots will then propagate up to the brain. And then I think probably the most common is via hypoperfusion. So again, if you have really dramatic stenosis or occlusion of an artery leading to the brain, it just stands to reason that that part of the brain is not going to get enough blood flow, and that will lead to ischemia and cell death. So Dr. Siegel actually published a paper in Stroke in 2012 that looked at 22 patients with PHACE and arterial ischemic stroke. The presentation varied, so most of them presented acutely, but 6 out of the 22 had a delayed presentation. And this may have been due to the fact that, a lot of times we do see a delay to diagnosis in pediatric stroke. People don't really suspect it. The symptoms can be very nebulous at times, very vague, and so it can be hard to make the diagnosis in an acute setting. So just a plug that pediatric stroke does happen, and we should be aware of the signs and symptoms. So you can see here in the acute presenting symptoms that seizures alone were the presenting symptoms in 3 out of 15 cases. And this is actually a fairly common presentation of pediatric stroke. Seizure at stroke onset occurs in about 30%. And so people will say, oh, it's just a kid having a seizure, and treat them for seizure. But when they then notice a hemiparesis that's not improving after the seizure has resolved, then people start to think, okay, maybe we should do neuroimaging. So I will almost always image a child with no prior seizure history, first time seizure with a hemiparesis. That's a kid that you might want to think about calling a stroke code or sending to the scanner. So the majority of the cases of stroke did have narrowing or non-visualization of at least one of the major cerebral vessels. And there was definitely a higher rate of aortic anomalies in this population as well. So I think really for me, the most important thing and the most difficult thing for these patients is to try to distinguish a static arteriopathy. So did the blood vessel just form small and will remain small and the same degree of small their whole life? Or is this an arteriopathy that's going to get worse over time? So we definitely see both stripes in this syndrome. Here's just a case report actually from the literature. This is a 7-month-old with a right facial hemangioma that extended to the neck, shoulder, and back. This child presented with focal seizures at 4 months of age and had a CT that showed a hypodensity consistent with a right MCA stroke. So when we did the imaging, or when they did the imaging, you could see that, I don't know if I have a pointer here, but there's actually complete absence of the internal carotid artery on the right. And so we didn't know, was this aplasia of the carotid artery? Was it just never formed to begin with? There are some ways to distinguish that on neuroimaging, but luckily this child had actually had imaging 1 month prior, and actually we did see a diminutive ICA. So this is a case where you can see that there was a progression leading to stroke. So how do we risk stratify for ischemic stroke in this syndrome? So we sort of have 3 different categories: low risk, medium, and high risk arterial anomalies. So it's always interesting to me to have residents and medical students in clinic with me seeing one of these patients, because they almost always will have at least one persistent primitive embryonic artery. It's a great lesson for embryology, because the anterior and posterior circulations were actually connected up to about 4 weeks of life. The internal carotid artery completes its development again by about 4 to 5 weeks. And you see basically initially there's all these connections between the ICA and the vertebral arteries, and then these slowly regress, and so we don't typically see them on normal scans. But in these cases, we often see some of these primitive embryonic remnants. So this is just an example here of, this is the basilar artery, and it's connecting with the internal carotid artery here, and that's an example of the persistent hypoglossal artery. Here's a normal example by way of comparison. So here's the basilar artery, which is comprises the posterior circulation. So sometimes we can also see that the arteries take kind of an anomalous course. They may loop more lateral than we're used to seeing. We can see, traditional variants of the circle of Willis that are not flow limiting, and these are felt to be very low risk. So usually you'll get an initial screening scan. Typically here we'll do kind of a feed and bundle in the neonatal period or early in infancy. Ideally before they need anesthesia, if they have a facial hemangioma that we're worried about. And then after that, if we see those primitive embryonic vessels, we'll simply just routine neurodevelopmental checks. And then if any neurologic concerns, you can refer to pediatric neurology at that time. So medium risk is kind of a more murky category, and I think sometimes it can be very hard to distinguish medium and high risk vessels. You can see just kind of looking at this picture that these are really kind of tortuous vessels. They're very loopy and kind of kinked, and it's very hard for me even for some of these to distinguish what's even going on. But I think here we see kind of an accessory left middle cerebral artery. Here you can see sort of a dilated anterior cerebral artery into the middle cerebral artery. Here you've got another anomalous course. So really these vessels are really anomalous and segmentally enlarged or ectatic, but the circle of Willis and the perfusion to the brain is still intact. And that's kind of the distinguishing factor. In this particular one, I would probably classify this as high risk because you can see the circle of Willis is not intact and there's really no ICA here on the right. So, I think, but it can be very tricky to make this distinction because there's all sorts of different nomenclature for some of the arterial anomalies, and we don't really know the significance, I think, of some of these findings. If you've got a patient though with blood vessels that are taking a really dolichoectatic course, meaning again looping around or kinking, or you're seeing ballooning out of certain regions or aneurysms, this would merit a referral to pediatric neurology. I'll usually tell families, okay, well, for this child, we're going to want to think their whole life about being really good about controlling vascular risk factors because they may only have a couple of good vessels that are supplying the brain. We might consider surveillance imaging when the child is old enough to tolerate a scan without anesthesia. That's generally my practice. So usually the child will get a scan when they're very, very young. I'll see some abnormalities are neurologically intact, and I'll sort of monitor yearly with neurochecks, but then have them do another MRA maybe around 6-7 years when they can lie flat without sedation. And then high risk. So this is basically complete absence, occlusion or stenosis of a major cerebral artery that compromises flow to the brain. And often this involves the circle of Willis, which is sort of the circle that helps supply blood. If one artery is out, then the circle can supply blood through detour arteries to the part of the brain that's lacking. So definitely if we get a scan and we see that, oh, there are silent infarcts that we see or old strokes, that would also concern me, certainly for that patient, and that would merit surveillance imaging for me. And again, in Dr. Siegel's series of the 22 PHACE patients who did have stroke, 21 out of 22 had a very severe underlying arteriopathy, most of those involving more than 2 blood vessels. So that's good to know. So here are some examples of high-risk arterial anomalies. So this is just a extremely stenotic left ICA leading into the circle of Willis. Here again, you have a non-intact circle of Willis, so you can see there's no connection here in the sort of pentagon shape. Here's again the normal example. Here again, we have a complete absence or a highly stenotic ICA on that side. And here you've got a really troubling appearance of the narrowing of the ICA there. I do want to highlight some Moyamoya syndrome. So Moyamoya, as many of you may have seen these patients, particularly at Stanford, we have a big Moyamoya group here. This is a progressive steno-occlusive arteriopathy that usually involves very specific segments of the circle of Willis. So the distal internal carotid artery or the proximal middle cerebral artery, it gets narrower and narrower over time, and in response, is the generation of these abnormal collateral vessels that are extremely friable. They're prone to breakage. They're prone to closing off. Moyamoya in Japanese means something like puff of smoke, and that's the name because those collaterals look like a puff of smoke. They're very hazy and very indistinct, and as you can imagine, very fragile. So these patients, again, it's progressive, so that is the concerning aspect. These patients very commonly do present with TIA or stroke, but may also present with headaches or seizures. In one small series, about half of PHACE patients developed progressive arteriopathy, and 3 of those had Moyamoya. And in a larger series of PHACE patients, about 8% had either a unilateral or a bilateral Moyamoya vasculopathy. So classically, Moyamoya vasculopathy affects kind of those regions that I mentioned in the anterior circulation. But in PHACE, kind of all bets are off. You can definitely see anomalies with abnormal collaterals involving the posterior circulation or different regions of the internal carotid artery. And we do see this present younger in this population. So typically Moyamoya in childhood presents around age 8 to 10. You can see here the mean age of diagnosis is really in infants and toddlers. So high risk imaging findings, again, refer to pediatric neurology. I do start aspirin for patients with Moyamoya. You can consider it in other high risk anomalies as well, depending on the flow. If the stenosis does appear flow limiting, I also do counsel my patients to avoid dehydration, make sure you're well hydrated. You may want to monitor pressure at home, but I think as Dr. Siegel alluded to, we don't contraindicate propranolol in these patients. We have not seen that stroke tends to be a problem arising from that very important therapy. And again, if you are seeing that over time, there's a progressive arteriopathy where the vessel is getting more and more narrow, we do also refer to pediatric neurosurgery to consider a surgical bypass if we're concerned that this progression is going to lead to stroke. So finally, a plug for just also the brain structural anomalies in PHACE. So again, about 40% have structural anomalies in PHACE syndrome, usually involving the posterior fossa. So cerebellar hypoplasia is the most common thing that we see. Again, usually on the same side as the hemangioma. The cerebellum is an important organ and it controls coordination and balance. We don't typically see frank incoordination and imbalance in these patients as the manifestation of this hypoplasia, but it may also have some involvement of cranial nerves because it's right adjacent to the brainstem. And then also intracranial hemangiomas may also be seen, and they often involve the auditory canal. So I think making sure you're doing a good hearing assessment in these kids is also important. So here's just the summary slide. This is from that recommendations paper that Dr. Siegel referenced earlier. But I think it's nice. It's very nice and organized. I do think it's hard sometimes to distinguish between medium and high risk, but in both cases, you do want to refer to pediatric neurology. And in my opinion, I do think perfusion imaging can also be helpful to understand if the region of the brain is getting enough blood flow. So if you have any questions, let me know. Thank you.
I'm Claudia Algaze, as been introduced, and I direct our cardiovascular connective tissue disorders program, hence my involvement in the PHACE multidisciplinary group. And I'll kick us off with a case. This is a real case that we managed about a year ago at Stanford. So female infant presented for routine echo in the context of evaluation for PHACE syndrome. And the echo showed transverse arch hypoplasia, but the anatomy was a little bit unclear. There was an arm to leg blood pressure differential. And because we really wanted a clear idea of what was going on, the patient underwent a chest MRA. It showed a tortuous corkscrew aortic arch and also proximal left carotid and subclavian stenoses. The patient looked pretty good in the NICU, and the heart function was normal. The perfusion to the distal extremities was also normal, and all the end organs were perfusing well. And so because the patient was really small, the decision was made to send the kid home with close follow-up, an aspirin therapy and propranolol, and then come back for a non-urgent repair. She subsequently was admitted electively, had a repair using an interposition graft from the ascending aorta to the mid-descending thoracic aorta. And her post-operative course highlights here some of the issues that one might see with this type of repair. She did have recurrent laryngeal nerve injury, so she had vocal cord paresis, and she had phrenic nerve injury. These are both nerves that really are in the surgical field of this repair, so were expected things that were discussed with the family. There were importantly no neurovascular complications. This is the first echo that was done, or one of the first echoes that was done for this patient. The image on the left is two-dimensional view of the aorta, the aortic arch, and you can see that there's some flow disturbance by colored Doppler as well. You can see it in sort of the rainbow colored area, but you can imagine that this is really not well delineated. And so the patient then underwent further imaging. This is a CT angio of the chest and up to the head and neck. The patient underwent that. You can see up here on the ascending aorta, you can see a very abnormal, tortuous ascending aorta into the descending aorta. It's fairly diffuse. There are areas of stenosis and post-stenotic dilatation. There's also areas of tortuosity. This is what it looks like by cath. Again, you can see a very abnormal course, tortuous aorta, areas of stenosis, and areas of dilatation. Here's what things look like after the surgery. You can see post-repair. On the left side is how the interposition graft anastomosis to the ascending aorta. And you can see a very big surgery, how the descending aorta anastomosis to the graft. It's said that this patient will be able to have this graft for at least 10 to 12 years. So the graft was actually placed, a pretty large graft was placed to be able to spare additional surgeries for a while. So as I mentioned, the patient did very well, as it was sent home after a couple of weeks and is currently followed by our team here. So the cardiovascular landscape in PHACE is very well highlighted and by an international PHACE syndrome registry study, which is the largest study done to date in this population. The reported prevalence, if you look at the literature overall, showed that 21 to 67% of patients with PHACE may have some cardiovascular anomalies. But in this registry study that better defined, I think, the cardiovascular anomalies. For example, they didn't include PFOs, they didn't include PDAs, which I think is an appropriate exclusion, highlighted that 62 out of 150 patients, or 41%, had some sort of cardiovascular anomaly. And of those, 37% required procedural intervention. Of the 62 patients, 92% of them also had cervical or cerebral artery anomalies, as Sarah just highlighted for us. And importantly, when cardiac anomalies and head and neck anomalies occurred, this significantly increases the risk for acute ischemic stroke. This is a modified table from the paper presented in the registry study, and it highlights the type of cardiovascular anomalies that we see. I put coarctation up on top because really it's the one that mostly requires surgical intervention, followed by any aberrant origin of subclavian artery, which may or may not require surgical intervention, depends on the associated anomalies. Ventricular septal defect, although does occur, in this study did not really require intervention. Most, if not all, of the VSDs close spontaneously. And then you can see venous anomalies, in particular systemic venous anomalies, right aortic arch, and vascular ring were also present. And you may note that in this table, the total anomalies don't add to 62 out of 150, and that's because each individual can have more than one anomaly, so the math doesn't quite add up. Contrary to typical coarctation, FACE syndrome coarctation really looks different radiologically, anatomically, and we'll see histologically as well. This is a picture of sort of typical coarctation, preductal and postductal. In preductal really would be the type of coarctation that you would see in a neonate. It's a long segment coarctation that occurs in the transverse arch and generally before where the patent ductus arteriosus would insert. And postductal that you would see in an older patient after the neonatal period, really around the area where the PDA inserted. But as we saw in prior slides and shown here, the coarctation associated with FACE syndrome is quite different. It's long segment, transverse, and you can see areas of stenosis adjacent to areas of aneurysmal dilation. Also, a significant corkscrew appearance, not only to the ascending aorta, but also to the head and neck vessels. And pretty importantly, it's defined by the absence of associated aortic or mitral valve anomalies. And this is contrary to what we see in typical coarctation, in which 50 to 80% of coarctation is also associated to mitral valve or bicuspid aortic valve. And a pretty important clinical point for us was highlighted in 60% of the registry cohort. And it's that both subclavian arteries are noted to arise distal to the coarctation. So when we're assessing for clinical coarctation with upper and lower extremity blood pressures, there may be no difference in those blood pressures, even in the setting of a potentially clinically significant coarctation. So we highlighted a few differences between typical coarctation, the coarctation that we would see in FACE syndrome, and it's also highlighted in the histopathology. On the right, you can see an excised segment of aorta from a typical coarctation. And here you can see there's intimal fibrosis, but the media has preserved muscle cells, preserved elastic fibers, and it does not really have medial necrosis. And as Sarah showed as well in her presentation, on the left side, you see a histopathology specimen from an excised coarctation from a person with FACE syndrome. And this shows significant scarring and necrosis, and actually almost complete obliteration and loss of arterial smooth muscle cells and elastic fibers in the media, as well as the intima. So really highlighting that there's a different pathological thing going on in FACE syndrome akin to an arteriopathy. When we look at brachiocephalic anomalies, they are much more present in FACE syndrome than the general population. You can see some percentages here. For aberrant subclavian artery, 21% versus 1.2%, a higher incidence of right aortic arch, and systemic venous anomalies like retroaortic innominate vein or bilateral superior vena cava. And I think probably one of the most important features and things to take home as part of this talk is that there seems to be a primary vasculopathy in FACE syndrome. So may require us to have a longitudinal management and longitudinal surveillance from an echo, from a cardiologic perspective. So we see that the primary vascular defect is a developmental dysplasia of large and medium-sized vessels. Ascending aortic dilation may occur without any other anomalies, as occurred in 11.2% in the PHACE syndrome registry study. And so even though a patient may have an initial echo that has no cardiac findings, it may be worthwhile to continue echo surveillance throughout their lifetime.
Okay, thank you so much, everybody. So the take-home points are that segmental hemangiomas on the forehead, central face, and beard distribution can be associated with a high risk of PHACE syndrome. Screening evaluation is recommended prior to starting propranolol whenever possible. And propranolol is generally safe in PHACE, but co-management with neurology, cardiology, and ENT is very important. So thank you so much for your attention. This again is the registry QR code. This is another helpful reference, Facing PHACE, which is also free, and the family advocacy group is listed here. So thank you.
All right, thank you. I've really been looking forward to this because this is a presentation that included 4 different departments. And I think above and beyond the extraordinary care of infants and children with this syndrome, I'd be curious to maybe, we'll have a few questions from the audience, and then maybe we can have a few minutes to talk about the larger issue of how do we optimally do multidisciplinary clinics at Packard. And Claudia, I'd love to know if this is something that lends itself to a clinical pathway, because as I was listening to all of the speakers, there's so many times we have to remember referring to these, things to think about and other referrals. And so what are the lessons we can learn from your really outstanding team that maybe have some broader implications for how we take care of children here at Packard? But first, these questions probably both are for you. Is there any correlation between infantile hemangiomas and AVMs noted later in life?
Set of patients with PHACE do have arteriovenous malformations. So with that progressive arteriopathy, it is a possibility, although not common. Sarah, do you agree?
Yeah. Okay, good. And then where should we place stork bite or nevus flammeus nuchae in our understanding of segmental hemangiomas?
Okay, great question. Yeah, so at birth, as I was mentioning, it can be really hard to distinguish these different vascular anomalies in infants, especially right at birth, because the stork bite or the nevus flammeus can be a very faint pink patch that can be located on the central forehead and on the back of the scalp. And then those tend to fade with time and are not associated with any congenital anomalies. And then the port wine birthmark can be associated with Sturge-Weber, and there's often confusion between PHACE and Sturge-Weber early on. But again, referral imaging and referral to neurology can help sort that out, as well as dermatology.
All right, next thing I was wondering is a lot of the lessons learned have come from the registry. And I think we've tried to quantify all the registries that we're part of here at Lucile Packard Children's Hospital. I think Grace was cataloging them, and we were well into the 100s, right? Karthik, I don't even know if we hit 200. Can you say a little bit about how this registry was established and how it's funded, since it's clearly been so important to this work?
So the registry was started at UCSF initially, and it has moved with me as I changed institutions over time. We're very excited to be here at Stanford now. It is we have our registry set up so that patients can enroll virtually. So we have a remote consent process, so patients don't have to be seen here at our institution. So I think that's a really critical part of it. And then in terms of funding, we have received generous grants from Stanford and the MCHRI and Wisdom grants, as well as funding from the National Institutes of Health.
Great. All right, Claudia, this last question is for you. And it's not a cardiology question, it's a clinical pathways question. So I think the last we looked, so the clinical pathways program, which supports the development of evidence-based multidisciplinary clinical pathways and their integration with electronic health record clinical decision support and quantitative assessment of impact. So I think last I looked, we had about 40 active clinical pathways. Are these the kinds of syndromes that lend themselves to clinical pathways? Or how do you think, how do we how could we do that to better coordinate all the complexities of these kinds of multidisciplinary programs?
Yeah, I think definitely. So all the pathways that you mentioned, Mary, are currently inpatient pathways. That's how we initiated a clinical pathway program in our first few years of development. I think of utility in clinical pathways as definitely helpful with high volume scenarios, but also with low volume scenarios that require a lot of coordination, a lot of people. And so if you're only seeing one patient every few months, that clinical pathway may very much help coordinate and make sure that care is evidence-based and standard. So while our clinical pathway program hasn't yet initiated support for ambulatory clinical pathways, I think this would fall into ambulatory, more of a different than episodic of care. It would be a longitudinal clinical pathway. It would span continuous care. I think it would be a very appropriate one.
Yeah.
And I think that's where we are headed with our clinical pathway program, is not just thinking of episodes of care, but how do you think about appropriate diagnosis, appropriate management, standard management? So I think this would be a really nice example of an application.
Good. Karthik, maybe that's something you and I can think about advocating for. Good. I think. Oh, okay. One last question, and then we'll be done. How should providers think about the PHACE clinic in relation to the vascular anomalies clinic? Okay. All right.
Shall I take that?
Dr.
Sure.
Karthik will bring us home.
So the vascular anomalies clinic really is broad-based. It covers all vascular anomalies. So I think it's a great entry point. Dr. Siegel and I both work in that clinic. And then we can be sort of a nexus to then get kids referred to the appropriate additional specialty experts. I think that in the end, sort of all roads do lead to the vascular anomalies clinic. That's a great place to start. And it's an easy thing for folks to remember. And then we can help sort out what next.
Other thing that I'd add is that we are also partnering with the cardiac connective tissue clinic as well for a lot of the other specialists that aren't represented in the vascular anomaly clinics. So.
Great. All right. Thank you very much. And we'll see everybody next week.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.